treat this disease better and understand our patients better. First, I think we all know the traditional simple definition of endometriosis. It's the ectopic endometrial glands and stroma. But I think this far oversimplifies what this disease really is. We know that although it may be glands and stroma that arise largely through retrograde menstruation and end up in the dependent areas of the pelvis, but we know when we see it, sometimes you can have the blue lesions or the typical blue or black powder burn lesions. Sometimes you can have white lesions. Sometimes you can have clear lesions. Sometimes you can have the big endometriomas. This doesn't behave like a single disease. I think that's one of the things we're learning, that this is probably a heterogeneous disease. We also know that the clinical presentation is quite varied. Sometimes patients present with pain. Sometimes they have no pain at all. We don't see them until they can't get pregnant and present with infertility. And other times they may have severe endometriosis and be completely asymptomatic. And we find endometriosis incidentally when we're looking at some imaging technique or surgery for unrelated reason. Even when we do have pain, we find that the pain doesn't correlate well with the stage of disease. Whether we look at dysmenorrhea or non-menstrual pelvic pain or dyspareunia, it's about the same at any stage of disease. So what you're seeing in the pelvis doesn't explain the whole disease. And what I'm here to tell you today is that this is not just a few blue dots in the pelvis. This is a much more complex disease. It's quite varied. It's quite heterogeneous. The dots that we see in the pelvis, what we typically think about when we think of endometriosis, really don't explain the pain, don't explain the symptoms, don't explain this disease. Not only that, there are so many other symptoms that are associated with endometriosis. We focus on the pain because that's often the number one complaint of the patient, or the infertility when they have that. But we know that there are affective disorders, clearly higher in women with endometriosis, depression, anxiety. We know that there's a systemic inflammation. We know that these women have a lower BMI. They have bowel dysfunction. They have bladder dysfunction. They're fatigued. And even now we've got data showing in the long run they're at higher risk of cardiovascular and other long-term diseases. So it's, again, not just a simple gynecologic disease in the pelvis. It really has an effect throughout the whole body. That we now have to start to think of endometriosis as a systemic disease that affects almost every organ system. And here I reference one of the recent reviews we wrote describing this phenomenon. So let's get to the injected endometrial cells contribute to not only the epithelium, but the stroma, the leukocyte population, and the endothelial cells. So they can make everything needed for endometriosis. And retrograde menstruation certainly does play a major role in the etiology of endometriosis. But I don't think that's the whole story. Sampson's theory, although it may explain most endometriosis, doesn't explain endometriosis outside of the peritoneal cavity. Doesn't explain endometriosis in the lung. Doesn't explain endometriosis in the brain, places where we not infrequently find endometriosis. And it certainly doesn't explain endometriosis in men. In the old days, when men with prostate cancer were treated with high doses of estrogen, some of them developed endometriosis. That's certainly not from retrograde menstruation, nor from hematogenous or lymphatic spread of endometrial cells. There must be another source of endometriosis. So many years ago, we asked whether stem cells could contribute to endometriosis. Could stem cells travel and differentiate into endometrium in inappropriate locations? And we looked first at bone marrow derived stem cells. And bone marrow has not only the hematopoietic stem cells that we're all familiar with, that are used for bone marrow transplant today, but it also has mesenchymal multipotent stem cells that can give rise to cells in solid organs. And we reasoned if bone marrow could give rise to all these different cell types, well, certainly we'd expect a tissue like endometrium, they might be able to contribute to a tissue that has such dramatic regeneration in every menstrual cycle. So what we did, a very simple experiment in mice, this was several years ago. We took bone marrow from male mice, transplanted it into female mice, and then looked for Y chromosome as a marker of the origin of those cells. So we assessed Y chromosome by Y chromosome FISH, fluorescent in situ hybridization, and this is what we saw. The upper left A is a control. The red dots are the Y chromosome by fluorescent in situ hybridization, or FISH. And this is a male control. Most of the cells you can see have a Y chromosome. B is the uterus of a female that got a female bone marrow transplant, no Y chromosome cells. C shows an epithelial cell in the uterus of this mouse from a male bone marrow cell that's derived from the transplanted male bone marrow. And D shows a stromal cell, again, of bone marrow origin. This shows that these cells can contribute to endometrium, and I won't show it here because of time limitations. We looked at a lot of other markers to really show those are indeed epithelial and stromal cells, and not just a leukocyte migrating through the uterus. And we also looked many years ago, again, humans, where we showed the same thing. We took women who'd had bone marrow transplant. This is in the old days when they took whole bone marrow aspirates. These women all had chemotherapy and total body irradiation, followed by bone marrow transplant. We looked at women with a single HLA antigen mismatch, so we could determine the origin of any cell type. And the brown here shows the mismatched HLA antigen. So on the left, you can see the epithelium. This is the donor cells stained in brown. You can see them intercalated into this epithelial layer. And you can see the same in the stroma on the right, that the brown cells show the mismatched HLA antigen, showing that they are donor-derived. The arrows point to these brown cells. The arrowheads point to cells that are not stained brown. Those are the resident or endogenous stromal cells that were there before the transplant. And these red cells are dual stained with another marker, CD45, of leukocytes. So those are the white blood cells that are all of donor origin after bone marrow transplant. But again, it shows this happens in humans as well. They can go to endometrium and in endometriosis. This is a model where we look at the endometriosis as well after donor bone marrow transplant. And you can see that not only do they contribute to the lesion, but they start to contribute to the vessels that feed the lesion and some inflammatory components outside of the lesion that in total will create new endometriotic lesions. So bone marrow certainly contributes to endometriosis. It's a novel origin for endometriosis. Stem cells can contribute to the disease and stimulate the growth of pre-existing disease. I think this accounts for most endometriosis outside of the peritoneal cavity, when we see it in the brain or in the lungs. Not only is it a novel origin of endometriosis, it's really a novel mechanism of disease, that stem cells can ectopically differentiate inappropriately, causing disease. I think endometriosis will turn out to probably be the first of many diseases where this is a mechanism of disease. Not only did we find that stem cells can contribute to the endometriosis, but we also find that the stem cells leave the endometriosis. When we transplant endometriosis in a mouse model and we track stem cells in the circulation, we find that they are increased in the circulation of these mice immediately and for some weeks after transplant. These are not differentiated endometrial cells that are the majority of cells that migrate through the bloodstream. These are the stem cells that are in the endometriosis. So our new model of endometriosis, at least of the cell biology of endometriosis, thinks of endometriosis as a disease of cell trafficking. That's not a surprise. We've always thought of endometriosis as a disease where cells track from the uterus out the fallopian tubes into the peritoneal cavity by retrograde menstruation. It's always been thought of as a disease of cells moving throughout the body. But now we also know there's a contribution of bone marrow to endometrium and endometriosis. And I draw a little thicker arrow towards the endometriosis because endometriosis, because of some of the inflammatory cytokines produced, actually attracts more bone marrow cells, competes them away from the uterus, may contribute to the infertility associated with endometriosis. But not only that, the endometriosis has modified stem cells that leave the endometriosis and migrate throughout the body. So it really is a disease of cell trafficking throughout the body. The other way that I think endometriosis may contribute to this systemic disease, not just, again, localized to those few dots in the pelvis. We see that stem cell trafficking is one way. But the other way that we've studied in the past few years has been microRNAs. Now, microRNAs, for those of you who are not familiar with them, are these small RNA molecules. They are located in the genome. They are transcribed but not translated into protein. Then they're heavily processed and eventually processed to these approximately 20, 22 nucleotide single-stranded RNA molecules that can bind to messenger RNA. And when they do, they generally either block translation or lead to degradation of that RNA. So they generally block the translation or block the expression of genes. We've seen that several play a role in endometriosis. This is from one of our papers several years ago, where we show that all of the LET7 family of microRNAs, one of the first microRNAs discovered, they're all decreased in endometriosis, and the red there is particularly aggressive severe endometriosis. They're even further decreased. Well, we know that these microRNAs not only are made in individual tissues, they are also incorporated in extracellular vesicles or microvesicles or exosomes, or even freely secreted into the circulation, where they can have effects far from the cell they're produced. Again, systemic effects throughout the body. And this may be a way that endometriosis communicates with some of these other organs, creating the symptoms that we've shown. So we asked also if we could use these serum microRNAs as biomarkers, and indeed we studied all of the microRNAs that were known at the time, and we found that several were increased and several were decreased. And we then looked to see if we could use a subset of those that had the biggest differential to create a biomarker of endometriosis. And here we look at 6 different microRNAs that when we test in a population of patients with endometriosis, obviously with a training set, we can create a formula that gives us a perfect area under the curve in this receiver operator characteristic curve. When we come back with a separate set of individuals and test again, you still have a very high area under the curve, high sensitivity and specificity of this test. But of course, these microRNAs aren't made just so that we can develop a biomarker. We asked, what are their functions throughout the body? Do they really cause some of the systemic manifestations of endometriosis that we see in our patients? We looked at the effect of these microRNAs in causing inflammation. And here we use macrophages. We know macrophages are altered in endometriosis. And the black bars represent treatment with microRNAs that mimic what we see in the circulation of women with endometriosis. Here you can see on the left, we either increase microRNA 125, which is elevated in endometriosis, or we decrease LET7, which I showed you is lower in endometriosis, by using a LET7 inhibitor. So the 2 black bars show mimicking the conditions of endometriosis. When we do that in macrophages, we get increased TNF-alpha production, increased IL-1 beta production, increased IL-6 production, increased IL-8, increases in all of the inflammatory cytokines that we typically associate with endometriosis. So microRNAs are one way that endometriosis communicates with the immune system to create this whole body inflammation. We also know that women with endometriosis have a low BMI, and I've even heard it said that having a low BMI is a risk factor for endometriosis. I think that's not true. It's quite the opposite. In our animal experiments, we're able to show that causing endometriosis, creating endometriosis in an experimental model, leads to weight loss. So the endometriosis has a metabolic effect that was previously unrecognized. So we cause endometriosis, it leads to decrease in weight, decrease in body fat and percent body fat.
How does that work? Well, at least some of it is through a metabolic effect on the liver. And I won't go into all the details shown on this slide, but suffice it to say that many of the enzymes that you'd expect that would lead to weight loss are changed in the liver in response to endometriosis. Again, in an experimental model, we can create endometriosis versus a sham surgery and show that it causes these effects in the liver. And I won't show you here today. We haven't published yet. We have some data that much of this is driven by those microRNAs that I've shown you earlier. It also has an effect on adipose tissue. So there's a metabolic phenotype directed by changes in adipose tissue. And here on the left, I do show either decreasing LET7 or here mRNA or microRNA, rather 342 is another one that we found altered in lower, rather higher in endometriosis. When we either treat fat cells with a 342 mimic or a LET7 inhibitor, we get increases in leptin, increases in adiponectin, changes in IL-8, hormone-sensitive lipase that drive this metabolic phenotype in adipose tissue. And we also, I won't go into all the details, but on the right here, you can see we look at stem cell composition of adipose tissue in our animal model of endometriosis. There are fewer adipose stem cells in mice where we create endometriosis. So there is a metabolic phenotype, at least partially driven through effects on adipose tissue and liver, that's active in women with endometriosis. Finally, I want to get to the effects on the brain and behavior. Again, we know that women with endometriosis have a greater incidence of fatigue, of central pain sensitization, of anxiety, depression. And sometimes we hear derogatory things said about women with endometriosis, that, oh yes, they're just more sensitive to pain and more anxious, and that they complain more. I always get very frustrated hearing that, because we here show, and I'll show you in the next slide, our animal model, that endometriosis actually is causing the anxiety, is causing the depression, is causing the pain sensitization. Where in this animal model, again, we can create endometriosis versus sham surgeries and look at the brains of these mice. And after we create endometriosis, as shown in the orange, we see changes in gene expression of several genes in the brain. We see changes in the electrophysiology of the brain, as shown in the upper right. But these changes in brain physiology lead to behavioral changes in these animals. We first look at anxiety. An anxious mouse will spend more time in the corners of a box and less time in the center of the box, and these tracings show that. And you can see that the time in the center of the box, which is a measure of anxiety, when they huddle in the corners rather than spend time in the center of the box, they're more anxious. And you can see after a few weeks here, the mice with endometriosis in orange are more anxious than the control mice. We test pain sensitization by using a hot surface that we put the animal's paw on and see how long it takes for them to withdraw the paw, to sense that as a warm sensation. And the mice with endometriosis withdraw their paw faster. They're more sensitive to pain. And we look at, to test depression in a mouse, we hold the mouse by its tail. A depressed mouse will lie limp and not struggle for some time to get away, whereas a non-depressed mouse immediately tries to get away or very rapidly tries. And you can see that immobility time is longer in the mice with endometriosis. So endometriosis causes direct effect on gene expression of the brain, electrophysiology of the brain, leading to the behaviors we see in women with endometriosis. So endometriosis causes effect on inflammation, on the liver, on adipose tissue, on the brain. It really is a systemic disease. I think when we look in the pelvis and see those blue dots, or that endometriosis in the pelvis that we operate on, we're really only seeing the tip of the iceberg. That endometriosis really is a chronic systemic disease. The systemic nature of the disease probably explains the extensive symptoms we see with endometriosis, those that we talked about. And stem cells and non-coding RNAs, such as MicroRNAs, and systemic inflammation are some of the mechanisms that mediate these long-range whole-body effects. So the clinical implications for patient care are the following: that the varied presentation and the diffuse symptoms have sometimes made it difficult for practitioners who are not expert in endometriosis to diagnose the disease. We need to start thinking about incorporating all of these symptoms as part of endometriosis and not start chasing other diseases when they're present. We have to recognize these systemic manifestations and listen to our patients. And the other implication is, while surgical therapy treats local disease and may actually turn around some of these microRNAs and inflammatory insults, you may need medical therapy to treat the systemic manifestations of the disease. And I think that future therapies will include agents that will specifically target some of these signaling mechanisms, that will target this disseminated effects of the disease, including effects on the brain, metabolism, inflammation, and others. So I'll end with this quote: that a focus exclusively on pain underestimates the true consequences of endometriosis and the patient's full disability. We really need to rethink of endometriosis as a systemic disease, and the pathophysiology that I've described to you here today really